Okay, welcome back to part 4 of our neurological emergencies. We're going to get into stroke signs and symptoms. So we've already talked about the anatomy and physiology of the actual brain in part 1. We've talked about the different types of headaches in part 2, and we've talked about strokes in part 3. Now we're going to really talk about the signs and symptoms of the strokes that you guys are going to be able to recognize this as soon as you guys actually make patient contact. Okay. So it depends on the area of the brain in which the actual blood flow is being deprived of. All right. However, most of the time, we're going to see some kind of behavioral change or some kind of altered mentation. Okay. We can have some kind of unilateral deficit. What do I mean by unilateral? They can't move their left side. They can't move their right side. Okay. That's what I mean by unilateral. They can have poor balance and lack of coordination. All right, these people can almost appear to be intoxicated when they stand up. All right, their cerebellum might be off a little bit, and they really can't control their motor functions. We might see facial droop. Okay, and remember, we already talked about this a little bit, but when the actual spinal cord comes through the foramen magnum of the skull, it twists. So the left side of the head or the left side of the brain controls the left side of the face and controls the right side of the body. So if we have a left-sided stroke going on, we're going to see, right? We're going to see facial droop on the left side of the face. They might have irregular pupil size on the left side. They might be drooling out of their left side, but they won't be able to move the right side of their body. Vice versa, if I have a stroke going on the right side of my head, they're going to have right-sided facial droop. They might have pupillary changes on the right side. They might be drooling from their right side, but they won't be able to move the left side of their body because the spinal cord twists as it goes through the foramen magnum. They could have difficulty speaking, right? Maybe they can't find the words they need to say. Maybe they're having a hard time finding the words they need to say. Maybe they're having a hard time with pronunciation. Maybe they can't talk at all. And this is something that I want you guys to really kind of think about and put yourselves in the patient's shoes. Let's have some empathy here, okay? Maybe even a little bit of compassion, right? Think about it. If you're in a situation like that and you can't talk, right? You know exactly what's going on around you. You're coherent to everything of your surroundings, but you can't talk. Okay, that's probably going to be a little scary for your patient. All right, so tell them tell them that I understand that you're going to have problems with talking. Tell them I believe you are having a stroke. Okay, we're going to get you to the closest, most appropriate facility to fit your needs. I need you to try to relax. Okay, that's therapeutic communication. Don't tell them it's going to be all right. Don't you tell them it's going to be all right. Okay? You have no clue. Okay? Difficulty swallowing. Man, there's something scary for EMS, right? We're airway ninjas. We love our airways. We are very good at protecting our airways. And remember, the only way to guarantee that if a patient has a patent airway truly is if the patient is able to swallow. Okay, if they're having a difficulty time with swallowing, we could have some serious airway issues that we need to deal with as we're going to the hospital with this patient. They can have visual changes. They could develop tunnel vision. They can lose their peripherals. They can lose their sight in one eye. They can lose sight in both eyes. But really, we're going to see differences in pupils. And usually what we see when we're talking about differences in pupils is if I'm having a left-sided stroke, my left side pupil is going to be much bigger than the right side. Okay? Or I've seen pupils, blown pupils that look like the damn Pentagon. You know, they're not even round anymore. There's such a significant bleed going on in the head or some kind of ischemic attack going on in the head. And they can also be suffering from a very severe headache. So in our lovely corner of the world here in the land of enchantment known as New Mexico, we use 2 different types of stroke scales, basically. We use what's known as the Cincinnati stroke scale, which evaluates facial droop, arm drift, and speech. So we're going to look for facial droop. To figure out arm drift, what we do is we have the patient basically sit down, and we have the patient hold their hands out in front of them, like as if they're Superman, right? Not all the way up above their heads, but right in front of them, okay? And then we have them close their eyes and then turn their palms facing up. Okay, so they close their eyes, turn their palms facing up. And let's say that left arm starts to drop, right? They can't hold it up. That is a positive arm drift. When we do what's called the Superman, or we're testing for arm drift, that is using a lot of nerve endings in order to be able to control that. And because of the fact that we have taken away the patient's sight by having them stick out their hands, close their eyes, and then turn their palms face up, they can't evaluate where they are in space anymore if they are having a stroke. And one side or maybe both arms might start to drop, or the right arm will start to drop. That's what we call by arm drift. And then speech. Have them say something to you. The big one is you can't teach old dog new tricks, right? We use that one because linguists say that uses the most musculature in your tongue to see if your tongue is actually working or not. And that's another thing that we can use in order to help out with speech. We also do something called the LA Stroke Scale. However, the LA Stroke Scale is usually performed in a hospital setting. That's what our clinicians out here in New Mexico are really kind of used to performing. And then if our C-stat does turn out to be positive, and it's positive if we just have facial drip, if we just have arm drift, or if we just have speech, or we have 2 out of the 3, or we have 3 out of the 3, okay? The C-stat, if the Cincinnati is positive, we do this to help identify the difference between an ischemic and a hemorrhagic stroke. If we have a positive Cincinnati, we're going to evaluate for what's called the C-stat, and we're going to talk about that here in a minute, to help us identify a large vessel occlusion. Okay, so these are straight out of your book. You got tables 9 and 10. Table 9 kind of explains the Cincinnati pre-hospital stroke scale. Please make sure that you guys are looking that over. And then table 10 kind of talks about the Los Angeles pre-hospital stroke scale. And really the Los Angeles is basically the Cincinnati with a couple other components thrown into it. So make sure that you guys look over this, so that you guys can kind of see what's normal and what's abnormal, and kind of look at exactly what each test is looking at. You guys do need to know the Cincinnati pre-hospital stroke scale and how to perform it. You guys just need to know that the Los Angeles pre-hospital stroke scale is one of the 2 stroke scales that we use in the state of New Mexico. Okay, the C-stat is kind of new to our system. It's definitely not new to medicine, but it is kind of new to our system. It's kind of popped its head up in the last couple years or so. But really what this is trying to do is, if we do have a positive on the Cincinnati stroke scale, we also perform this test as well. And what we're doing is we're looking at the actual patient's gaze. We're looking at arm weakness, and we're looking at the alteration of consciousness. Are they kind of confused and then not confused? Or do they have this real loose cognition, but then do they focus when they're answering questions? Kind of stuff like that, right? And basically the C-stat is there to help us confirm that, yes, we are technically dealing with a stroke on this patient. If we have a score of 2 or greater on this list, we are more than likely dealing with a large vessel occlusion. You guys will get a little bit more training on this when when you guys actually get into your service. I'm not going to spend too much time on this, but I want you guys to know that this is done after we have already confirmed a positive Cincinnati, and anytime that we get a score of 2 or more, we are definitely thinking about a large vessel occlusion. Okay, when we're talking about unilateral motor deficit, this is any kind of numbness or weakness, possibly clumsiness, of any arm, leg, or the side of the face. Okay, and usually if it's the arm and the leg, it's the same arm and the leg. So it's the same side of the body, arm and leg. It could be the left side, arm and leg. It could be the right side, arm and leg. When we're talking about motor control, remember, please remember this, guys. When the spinal cord goes through the foramen magnum, it twists. So the left side of the brain controls the right side of the body, and the right side of the brain controls the left side of the body. Okay? That just kind of helps us kind of with our detective skills when we're thinking about possibly this patient is having a stroke. So this is a generalized signs and symptoms stroke slide for you guys. Definitely facial drooping, sudden weakness or numbness in the face, arm, leg, or one side of the body. Loss of or lack of muscle coordination, also known as ataxia. Okay, it almost appears as if somebody is intoxicated when they're trying to move. Sudden vision loss in one eye or blurry vision, loss of peripherals, tunnel vision, double vision, difficulty with swallowing. It could be a decreased or even an increased level of responsiveness. They might be a little too jittery for you guys. That can also be a sign and symptom of a stroke. And then they could have some kind of speech disorders known as dysphagia, okay? D-I-S-P-H-A-S-A-I, okay? We're also going to talk about dysphagia with a G later on, but dysphagia with an S, okay? Dysphagia with an S is speech disorders, okay? Dysphagia with a G has to do with the GI system. But for now, speech disorders is also known as dysphagia. Depending on where the actual stroke is in the patient's brain, where that actual occlusion is, we can have difficulty expressing thoughts, or they might not be able to understand you, or they might have a hard time finding the words to answer your questions. They could have paralysis in one or more extremities. They could be complaining of that sudden or severe headache, any kind of confusion, dizziness, weakness. They can become combative. Or they can have slurred speech, which is known as dysarthria. It's known as slurred speech, where it sounds like they've had a little too much to drink. So here's a picture of facial droop. You can see that the actual symmetry of this young lady on her face is off. It's definitely more visible on the left than on the right. This is a shot of her when she was reporting signs and symptoms of a stroke, and this is what she now looks like afterwards on the right once the thrombolytic therapy had taken place. But you guys can see it looks like her face is melting off on the left hand side there. She doesn't have the cheek or bone structure like she does on the right side of her face. She's lost her dimple on the left side of her face, and you can really see it in the mouth, how that mouth is kind of starting to curve downward. Even on the right, after this was all said and done, she looks like she has those droopy eyelids still on the left. She's kind of lost the crease in her actual cheekbones on the left-hand side there, and her mouth is basically back to the same size, but or the same horizontal plane, I guess is the best way to put it, but you could still see a little bit of a facial droop on the left-hand side there. So when we're talking about strokes that actually affect the left hemisphere, usually it might cause aphasia. That patient is not able to talk at all. It might have hit their speech center, and remember that most of the people's speech centers are found on the left side, in the left hemisphere of their brain. And aphasia, the term aphasia just means that you can't talk at all. Could be mumbling, right? Basically the definition of aphasia is the inability to produce or understand speech. Okay, and again, these speech problems can vary, right? They might get stuck on a word. They might sound like they have a stutter. It might sound like they are mumbling. They can't find the words to answer your questions. They don't understand the words that are coming out of your mouth. Or they could have some kind of like repetitive questioning or something like that. We'll talk about that more specifically when we get into trauma that has to deal with head injuries and whatnot. And then also, if we do have a severe stroke going on the left side, remember that we could also have paralysis on the right side of the body. When we're talking about strokes that affect the right side of the brain or the right hemisphere, remember that this is more than likely going to cause or could cause paralysis of the left side of the body. Usually these patients are able to understand language and are able to speak, but their words can be slurred. Or they might even ask you if you're slurring your words, or they might say, can you pronunciate your words a little bit better for me? Make sure that you're kind of talking a little slow when we're dealing with a stroke patient so that they have time to actually process the information and think about how they want to answer you. All right. The problem with a right-sided stroke, and this is very interesting, there's been numerous studies on this, is that usually when it happens in the right side of the brain, the patient has no clue, or they're completely oblivious to what's going on. According to them, according to their brain, they sound like they're speaking fine, but they're mumbling and bumbling, right? So this could be a very confusing time for your patients. Let them know that, look, I believe you're having a stroke. I understand that you might think that you are talking okay, but you're not. All right, let them know that, okay? Kind of put them at ease a little bit. We could have that ischemic stroke turn into actual bleeding on the brain. Can turn into a hemorrhagic stroke. And we need to make sure that specifically the patients with high blood pressure, a history of high blood pressure, okay? Their high blood pressure may be the cause of the bleeding, all right? And it could be caused by the bleeding as a compensatory response. And we're going to talk a little bit about intracranial pressure. When we're talking about bleeds in the brain will constrict all the vessels in order to try to get more blood up there. It's the brain's natural response. It's the brain's way of thinking that it's doing itself good when it's actually doing itself worse. All right. But by increasing the blood pressure, or an increase in blood pressure, is definitely a very important sign. All right. If we have significant drops in blood pressure, we can assume that the patient is actually starting to get worse. Okay. So it's kind of like shock, right? We don't want their blood pressure too high. We don't want their blood pressure too low. Okay. But we do need to keep monitoring that blood pressure so that we are able to identify when those significant changes actually occur, so that we can pass that on to our friends in the hospital. And then on top of all this, for you guys to be concerned with, there are things that actually can mimic a stroke. And the big one is hypoglycemia, or low blood sugar in the blood. This is a problem that diabetics have. We're going to talk about that more when we actually get into the endocrine system. We're going to talk about the postictal state, and it's usually the period after a seizure. After somebody has a seizure, they enter what's called the postictal state after the actual seizure activity has stopped. This can last anywhere between 5 and 30 minutes, and this is basically a period of confusion. They just had this massive amount of electricity misfiring in their head. Their brain's trying to come back to, trying to figure out what the hell just happened, making sure that everything's running the way it's supposed to be, kind of doing its own little self-check. And the patient's pretty confused at this time. They could be so confused that they could be combative with you, right? We're going to talk about that more here in a sec as well. And we're also going to talk about subdural and epidural bleeding and the difference between those. Subdural means that it's below the dura mater. Epidural means that it is above the dura mater. So an epidural bleed is bleeding in between the dura mater and the actual skull itself, where a subdural bleed is actually below, anywhere below the level of the dura mater. And we'll talk about that again here in a second. All right, so what do we need to do? What can we do when we're dealing with the stroke? Okay, so when we're talking about care, we're going to support the ABCs just like we would any other patient. Okay, we want to make sure that airway, breathing, and circulation are under our control. Okay, if it's not under our control, then we need to try to make it underneath our control. Okay, and remember that when we're dealing with the stroke, we can have some serious airway issues. That patient might not be able to swallow, where we might have to do some suctioning for them, or possibly even dropping a device into their airway in order to help maintain its patency. We need to transport to a stroke center, and basically all of our downtown hospitals, Presbyterian, I believe Lovelace is still one, but Presbyterian and UNM is definitely still a certified stroke center. I'll have to find out about Lovelace. Lovelace is kind of interesting. They kind of go back and forth on their stroke center capabilities, but I still believe they are technically a stroke center. I'll have to find that out for you guys. I'll let you know in class this weekend. They might need manual airway positioning. We've already talked about that. And we might need to use some suction in order to keep their airway open and patent. We need to make sure that we protect their paralyzed extremities. If they can't move the right side of their body, we need to make sure that we are protecting their right arm and their right leg. Okay? Just because they're paralyzed doesn't mean that the patient doesn't need them anymore. Okay? They are still part of the patient. We still need to make sure that we are not causing more harm to our patients. And we want to make sure that we do not damage those extremities when it comes down to it. Keep the patient informed. Talk to your patients, okay? Even if they appear to be unconscious, they can still hear you. Let them know what's going on, okay? And then make sure that you guys get as much information from the scene as you can. Specifically, when was my patient last seen normal? That's a big one. 3 hours for National Registry, 6 hours for the state of New Mexico.